Welcome to Chapter 18, Quality Production and Monitoring. We are beginning Part 1 of this comprehensive lecture series based on the Sterile Processing Technical Manual, 9th edition. In the realm of sterile processing, SP, the word quality is not just a corporate buzzword or a slogan on a wall, it is literally a matter of life and death. It is the most critical safety issue we face. A single error, such as a tiny hole in a blue wrapper or a microscopic piece of bioburden left on a rongeur, can result in a surgical site infection, SSI, or lead to a cancelled surgery. Therefore, when we discuss quality management, we are discussing the overarching system that ensures every instrument is safe every single time. Let us define exactly what we mean by quality. By definition, quality is the consistent delivery of products and services according to established standards. It measures how well the department meets the needs of its customers. However, to truly understand this, we must identify exactly who our customers are. In quality management, you must distinguish between two types, internal customers and external customers. Internal customers are the people inside the healthcare system who interact with the sterile processing department directly on a daily basis. Examples include surgeons, operating room, or nurses, and hospital administration. External customers are people outside the daily operations who are affected by the service. This includes insurance companies and regulatory agencies like the Joint Commission, TJC. But most importantly, the patient is the ultimate external customer. Even though the patient never steps foot in the decontamination area, they are the ones who bear the risk of our work. When we attempt to identify and measure quality, we must understand the difference between subjective and objective data. This is a common distinction found in your workbook. Subjective quality is hard to measure because it is based on feelings or opinions. Examples include phrases like doing a good job or working hard. While positive, this is not how we manage a professional medical department. Instead, sterile processing quality must be objective. Objective quality is fact-based and measurable. Examples include data points such as 99.8% error-free tray assembly or all biological indicators passed. We often use benchmarking to compare these data points against national standards. We deal in facts, not feelings. We now move to the most frequently tested distinction in this chapter, the difference between quality control, QC, and quality assurance, QA. You must understand the focus and the action of each to pass your certification exam. First, let us look at quality control, or QC. The focus of QC is the product or the output. The action involves inspecting the item before it leaves the department to catch errors. It is a check at a specific point in time. Examples of quality control include checking a peel pouch seal for wrinkles, reading the result of a biological indicator, or inspecting an instrument for cleanliness under magnification. If you are holding an item and checking it, you are likely performing quality control. Second, let us look at quality assurance, or QA. The focus of QA is the process and prevention. The action involves collecting and analyzing data over time to prevent errors from happening in the first place. Examples of quality assurance include analyzing logs to see why wet packs increased by 5% last month, or auditing the training program to improve staff competency. If you are looking at data trends to fix a system, you are performing quality assurance. Understanding this transition from simply checking items to analyzing systems is the first step in mastering quality management. Having established the fundamental difference between checking products and improving processes, we must now examine the essential components required to build a successful quality system. To achieve true quality, a department needs more than just inspections. It needs a supportive infrastructure. Success in sterile processing relies on several key elements, starting with empowerment. Empowerment means granting staff the actual authority to stop a process if they see a quality issue. For example, a technician should feel safe stopping a washer line because the temperature is too low, or refusing to release a sterilizer load because the printout looks suspicious. If staff are afraid to speak up, quality fails immediately. Next, we must consider data collection. The rule is simple: you cannot manage what you cannot measure. Errors must be documented, not hidden. We must gather facts, numbers, and statistics to make decisions rather than guessing. This leads directly into process management. This component focuses on the system, not the person. When an error occurs, the question should be, why did the system allow the technician to make this mistake? Rather than just blaming the technician. This ties into the concept of standardization, which is the foundation of quality assurance. We must standardize how work is done so it is consistent, regardless of who performs the task. Two additional components mentioned in your technical manual are quality planning and staff members. Quality planning is the design phase where we decide what needs to be measured and set the standards before work ever begins. Staff members are the drivers of this system. They are the eyes and ears on the ground. Finally, leadership must provide the necessary resources, such as tools and training, and foster what we call a just culture. A just culture is an environment that focuses on system fixes rather than individual blame, creating a safe space for reporting errors. Now, we move to the most critical exam concepts regarding analytical methods. You must know the difference between the two major tools used to solve quality problems, specifically, which one is proactive and which one is reactive. The first tool is root cause analysis, or RCA. This tool is reactive, meaning it looks backward. RCA is used after an error, adverse event, or sentinel event has already occurred. Its goal is to find the underlying reason, or the root, of why it happened so it does not happen again. The primary technique used here is called the 5 whys. This involves asking why 5 times to drill down to the root cause. For example, if a tray was wet, we ask, why? The sterilizer was overloaded. Why? The staff was rushed. Why? We were short-staffed. Why? There was a scheduling error. That scheduling error is the root cause. The second tool is failure mode and effects analysis, or FMEA. This tool is proactive, meaning it looks forward. FMEA is used before a new process is implemented or changed. Its goal is to identify what could go wrong, which we call potential failures, and fix them before they cause harm. It is a prevention tool. For example, if we are buying a new robot, we ask, what could go wrong during cleaning? And then write a protocol to prevent that specific error before the robot ever touches a patient. Finally, let us review the standard quality programs and methodologies found in hospitals. You need to know the definitions for 5 specific programs. First is Continuous Quality Improvement, or CQI. This is the scientific philosophy that processes can always be improved and that quality is a journey, not a destination. Second is Total Quality Management, or TQM. This is a management approach where everyone in the organization, from the environmental services team to the CEO, participates in quality improvement. It focuses on long-term success through customer satisfaction. Third is Six Sigma. This is a data-driven method focused on eliminating defects. The goal is near perfection. The statistic you must memorize for the exam is that a process is considered Six Sigma if it produces no more than 3.4 defects per million opportunities. If you see 3.4 defects on your exam, the answer is Six Sigma. Fourth is Lean. This method focuses on eliminating waste. Examples of waste include wasted time, wasted motion, excess inventory, or overproduction. Remember the mnemonic: lean meat has no fat, and a lean process has no waste. Finally, we briefly mention ISO 9000, which refers to international standards that provide a global framework for quality management systems. Having covered the theoretical frameworks and management tools, we now move from the classroom to the department floor to see how these concepts apply in practice. This section is known as zone-specific monitoring. Quality looks different in each area of the department, and for your exam, you must know exactly what is checked in each specific zone. We will begin with quality in the decontamination area. The primary focus in decontamination is twofold: ensuring items are safe to handle and verifying they are mechanically clean. There are 4 key quality checks you must be familiar with. First is PPE compliance. We must monitor if staff are correctly wearing personal protective equipment, PPE, to prevent exposure to bloodborne pathogens. Second is disassembly. Quality assurance involves verifying that multi-part instruments are completely taken apart before washing. For example, stopcocks must be removed or opened to ensure the detergent reaches every surface. Third is chemical potency. We must test high-level disinfection, HLD, solutions using MEC strips, which stands for minimum effective concentration strips, and we must also verify detergent dilution rates. Fourth is cleaning verification. This is a critical quality control check. We use commercial test objects, such as TOSI packs or cavitation wafers, to verify that mechanical washers and ultrasonic cleaners are working correctly every single day. Now, let us move to quality in the preparation and packaging area. The focus in this area shifts to functionality, cleanliness, and completeness. This is where the most specific hands-on testing occurs. The first check is visual inspection. Technicians must use lighted magnification to check for residual bioburden, such as bone or blood, on clean instruments. The second check is functional testing. This is a major area for exam questions, and you must know how to test specific instruments to ensure they work during surgery. Let us review the specific tests. For scissors, they must cut specific test material, often latex or yellow rubber, cleanly at the distal tip, which is the last 1/3 of the blade. If they snag, they fail. For ratchets, you close the instrument on the first click and tap it against the table. It should not spring open. For forceps, the tips must align and meet perfectly. For laparoscopic instruments, you must perform insulation testing. This involves using an electrosurgical insulation tester to detect pinhole cracks in the black insulation coating. Even a microscopic hole can cause electricity to arc and burn a patient's internal organs. Visual inspection alone is not enough. For kerosene rongeurs, you must verify there is no bone or tissue trapped in the slide mechanism, and test the cutting action using a specific index card or test material to measure sharpness. The third check in this area is tray accuracy. This involves verifying that the count sheet, or recipe, matches the instruments in the tray 100%. The fourth check is package integrity. We must check wrappers for holes and inspect peel pouches for proper heat seals. A proper seal must be smooth, with no wrinkles and no gaps. Having completed our inspection of the preparation and packaging zones, we now advance to the critical final stages of the workflow: sterilization and sterile storage. We begin with quality in the sterilization area. In this zone, the focus shifts from visual inspection to ensuring that the parameters for lethality were met and thoroughly documented. The rule here is absolute: if it is not documented, it did not happen. There are 4 key quality checks you must master for this area. First is load control numbers. Every single item to be sterilized must be labeled with a specific lot number. This number is not random. It identifies 3 specific data points: the sterilizer ID, the load number, and the date of sterilization. This is essential for traceability. If a biological indicator fails later, we must be able to recall every specific item processed in that load using this number. This is the foundation of a recall policy. Second is sterilizer printouts, which act as the physical monitor for the cycle. At the end of every cycle, the operator must review the printout tape. You must verify and physically sign the printout to confirm that the critical parameters of time, temperature, and pressure were actually reached. This printout is a legal document that proves the cycle was successful. Third is wet packs. When a card is removed from the sterilizer, technicians must monitor for moisture. Any visible moisture on the outside of a pack or inside a tray constitutes a failure. Moisture acts as a highway for bacteria, a process known as wicking, which recontaminates the instrument. If you see water, the item is not sterile. Fourth is biological and chemical indicators. Quality control involves ensuring the correct tests were used for the specific cycle and load type. For example, if the load contains an implant, a biological indicator, BI, must be run within a process challenge device, PCD, and the load should be quarantined until the result is known. You cannot release an implant until the biological test proves the spores were killed. Once an item is successfully sterilized, we move to quality in storage and distribution areas. Here, the focus shifts to preserving that sterility until it reaches the patient. There are 4 primary quality checks in this area. First is event-related sterility. This is a critical concept for the exam. Modern sterility is not determined by time, but by events. We must inspect packages for tears, holes, compression, or moisture damage before dispensing them. If the package is compromised, the item is no longer sterile, regardless of the date on the label. Second is expiration dates. While the sterility of the instrument is event-related, the commercial supplies inside, like chemical indicators or disposable wrappers, often have manufacturer expiration dates. We must check these dates to ensure nothing has expired. Third is FIFO, which stands for first in, first out. This is the inventory rotation standard. Quality means verifying that older stock is moved to the front to be used first, while newer stock is placed in the back. This prevents products from expiring on the shelf. Fourth is temperature and humidity logs. We must perform daily monitoring of the storage environment. If the humidity is too high, it can compromise the integrity of the peel pouches or wrappers. If the temperature is too high, it can encourage bioburden growth. With the physical workflow now secured from decontamination to storage, we must address the administrative side of quality, including management, standardization, and policy. This section discusses administrative quality indicators. While technical quality focuses on the instrument itself, such as whether it is clean or sterile, administrative quality focuses on the oversight required to maintain the system. There are 2 major concepts here that often appear on exams: customer satisfaction and throughput. First, let us look at customer satisfaction. We must track complaints from the operating room. For example, if a doctor reports that the scissors were dull, that is a data point. While a single complaint is subjective in nature, based on opinion, if we track these complaints over time, they become objective data that reveals a trend. If 10 doctors report dull scissors in 1 week, we have a measurable system failure. Second is throughput. By definition, throughput measures the volume of work and how fast trays are processed and returned to the shelf. The critical balance in quality management is ensuring that high throughput, which is speed, does not compromise safety. A common pitfall in sterile processing is rushing to meet volume demands, which leads to shortcuts. Administrative quality monitoring ensures that while we are fast, we are safe. Next, we look at standardization. If you remember one thing about management from this chapter, let it be this: standardization is the foundation of quality assurance. The problem we face is variability. If every technician performs a task differently, you will get different results, and inevitably, errors. The solution is developing strict policies and procedures so that every technician performs the task the exact same way, every time. You cannot measure improvement if the process keeps changing. Standardization reduces variability, which reduces error. We must also distinguish between technical quality and administrative quality for clarity. Technical quality refers to the physical result. Is the instrument clean? Did the biological indicator pass? Administrative quality refers to the infrastructure. Are the policies and procedures current and accessible? Is there enough qualified staffing to do the work without rushing? Both are required for a functioning department. Before we conclude, we must define one final critical term, the sentinel event. A sentinel event is an unexpected occurrence involving death, or serious physical or psychological injury, or the risk thereof. Examples include surgery on the wrong body part or a non-sterile instrument causing a fatal infection. A sentinel event always triggers a root cause analysis, RCA. It is the most severe type of error, requiring an immediate reactive investigation to ensure it never happens again. This brings us to our conclusion. Quality monitoring shifts the department from guessing to knowing. Without quality management, a sterile processing department is constantly putting out fires, scrambling to fix errors after they have already happened. By using tools like FMEA and RCA, and implementing rigorous quality controls in every zone, the department moves from firefighting to fire prevention, stopping errors before they ever leave the department. The bottom line is simple. The patient on the operating table trusts us with their life. They deserve a sterile, functional instrument every single time. Quality is not just a department goal, it is our ethical promise to them. This concludes our study of Chapter 18, Quality Production and Monitoring.